Yes. So thank you. I'm here today to talk about an implementation science study that we are currently implementing at Sydney West TCRC. Just to put it in context for those who may not be familiar with implementation science, it fits within the broader remit of translational research. A lot of translational research is concerned with laboratory scientific discovery. There's another area that is focused on clinical trials and ensuring they're rapidly translated into practice. We're down what's called the T3 end, which is really looking at practice, gaps in practice, and trying to identify those gaps and respond and improve them. So that's the context. Some people, there's different names, some people call it improvement science, some people call it implementation science. So our team, as you can see, incorporates quite a number of people. It's bigger than that really. There's many more, all the people who've been working in the multidisciplinary teams, and the programs have also given kindly. We're also working closely with the innovations manager. Get it moving in the right direction. So in terms of our place, that's not the best map, of course, but just to let you know that the Sydney West Cancer Network is bigger than the Sydney West TCRC. It also includes the Nepean Cancer Care Centre, the Blacktown Oncology Centre, and the Palliative Care Unit at Mount Druitt. So we have we have a big area, lots of patients, but we also have very culturally diverse patients. Quite a number of our clients are from culturally and linguistically diverse backgrounds, and also lots of people who are socially and economically disadvantaged. Within Sydney West, MDTs, or multidisciplinary teams, are the primary vehicle for delivering cancer care. What we're interested in, though, is developing a wider program of multidisciplinary care, not simply the multidisciplinary meetings. That's obviously one important aspect, but we're looking beyond that because it includes training for registrars, clinical networks. So we're looking at building and strengthening high-performing program of multidisciplinary care, which is more than just MDT meetings. I'll use the term MDT now. Of course, some of you may know that implementation science is a very complex business. Part of the complexity comes from the fact that there's so many different terms and it's used so interchangeably. It also has overlaps with quality improvement, which Carrie and Jerry talked about this morning, although of course in the business of implementation science we're very concerned to ensure there's rigour around the research and the studies. And the key question for this particular study is what is the role of MDTs in implementation science and research, and how do we build their capacity and support that capacity to do, particularly from where we're coming, practice-based research. Many of our clinicians are very familiar with scientific discoveries, with clinical guidelines, the development of guidelines. This is a little bit of an unfamiliar territory for many of our clinicians. Another challenge in this field is that there's naturally variability in MDTs. It's you know, to some extent the variability would be expected and normal, depending on the tumour stream. So that's another challenge for us, is if we're trying to develop high-performing programs, you know, what does that look like, and how do we still allow for that variability within teams? And what type of variation is acceptable? So that just gives you an idea that of all the players involved in implementation science, because it's practice-based, and that's part of the challenge, and that's the complexity of it, is that we don't just need researchers, we need policy makers, we need behavioural scientists, because we're in the business of changing behaviour. We need communication theory, so it's definitely not for the faint-hearted, this particular type of research. And also another challenge is that in the literature, while we do know there is evidence that multidisciplinary care will improve patient satisfaction, clinician satisfaction, there's not a lot of evidence actually that it improves survivorship. I think most people, you know, enjoy multidisciplinary teams and those kinds of programs. It's definitely enhances communication. But we still are challenged by the fact that to date we've not actually been able to demonstrate that that a multidisciplinary team care does actually improve survival. So that's another challenge. We do know that the Cancer Institute is currently working on some draft guidelines. I'm not going to preempt them. I know they're in draft form, but I just wanted to point out that that's been helpful for us, because if we're trying to develop high-performing programs, then it is really good to have some idea about the broad domains that we can look at and work. So watch that space. In our current study, there's several phases. Phase 1 involved observations of MDT meetings across various tumour streams, and we also conducted semi-structured interviews with multidisciplinary team champions, leaders, clinicians, and then we've been recently involved in a priority setting process which is ongoing, where we're actually, out of the interviews and the observations, we've managed to observe some of the barriers and the enabling factors for research, and clinicians have kindly helped us identify those. So we've been trying to look at what are the priorities, what's the gap that we can actually address here that's doable. Our next phase that we're now moving on to is we're working much more closely to engage with quality improvement in a proactive way. You'd be aware that often quality improvement, or patient safety and quality, because of the nature of the business, they're often focused on responding or reacting to situations as they arise. But at Sydney West, we're very fortunate. We have Carrimar as well. Quality improvement is on the agenda, and we're looking at ways of proactively working with quality improvement, particularly in terms of helping us identify the data, the kinds of information we might need to collect, but also what might be the gaps in practice that need addressing. We're in that process at the moment. We've got several different interventions we're looking at, and we will be applying one of those to a particular tumour stream in the near future. So just to reiterate, phase 1, we looked at several tumour streams. They're listed there. And as I mentioned, we've conducted to date 18 semi-structured interviews. So the broad findings from those interviews and observations, and these are broad and preliminary, we're doing more fine-grained thematic analysis at the moment, but we have found that certainly within MDTs, most use, particularly T2 research, and what I mean around that is they're very actively involved in the development and the implementation of clinical guidelines and some basic science, and some teams are generating that. Small number, but there's some scientific work being generated. But we did find that very few of the MDTs that we observed were actually involved in what I've called T3 or practice-based research, and very few had any active involvement with quality improvement. Hence, awareness of T3 or practice research. These terms are coming from the Westfall model for translational research, which is used by the Institute. They talk about T1 being the basic science, T2 and T3. So awareness of T3 or practice research is quite low, and that it is a challenging field, how to make sure we're doing it rigorously, but obviously that's one challenge we're going to have to address. Also, the relationship of MDTs versus the individual in research is not clear. So we know we've got individuals in MDTs actively involved and engaged in research, but it's not always the case within the team. So it might be one or two people in the team, but not necessarily the whole team. And not all disciplines in MDTs are equally research active. So they're broad findings. And from those, we've looked at a preliminary gap analysis. So I'm reiterating to some extent, but as I said formally, there's no formal process because we don't have a lot of engagement with QI in identifying the improvement issues. We also know that we need to bolster the leadership. Carrie and Jerry talked about that. And coordination and support for the teams varies. And audit and feedback, that's obviously, we know that that's a powerful behaviour change agent, that often that's one of the most powerful things you can do to create behaviour change is to collect data and feed it back to the clinicians, but what data do we collect? We've then developed this model. My colleague Anna Jansen has been working on this model, and Tim Shaw has also contributed. And this figure really represents what we've identified as the enabling factors for those different types of translational research. We're obviously focused on the T3 petal, and the stem, as you can see, they're the factors that enable all of those across the spectrum of translational research. You need data, you need admin support, you need leadership, and business meetings where research questions can be fielded and discussed. But we're particularly focused now on the T3 petal and working with the QI people to identify particular gaps and data that we can be collecting and then implement an intervention in the near future. So just to reiterate, the key enabling factors that we've found to date, I've mentioned them, but they're the ones that we've identified from our interviews and observations as being key to building the capacity of this program of multidisciplinary care that will have a strong focus on practice research. Our next step, as I said before, we're completing this priority setting exercise. We'll be working at Nepean as well as Westmead to ensure that all clinicians are involved in that because we need their buy-in, obviously. Then we will be focusing on 1 or 2 tumour streams, and we're very excited because we're now at the moment engaged in some very proactive conversations with QI about the data we can collect and where we go from here. And we'll be piloting that we think at this stage it may be the upper GIT team, but we're still just waiting for final approval. And thank you.